good afternoon, and welcome to HS Connect's patient engagement and education series. We wanted to do this one specifically at the end of June, rounding out Pride Month, on the impacts of HS in the transgender community. So I first want to thank our sponsors, which are UCB, Sanofi, and Novartis, for sponsoring this educational webinar series that we're putting together. And I wanted to introduce Dr. Daveluy, who is our speaker for today. And he is amazing. And I don't know a ton about this topic, so I'm super excited to learn more about it. I know that it can be an issue in our community, so I'm really excited to hear what you have to share with us today. So please feel free.
Yeah, thanks so much, everybody, for joining and for viewing. And Brindley, thanks for setting this up, because this is definitely a topic that deserves more attention. And I hope I do it well. Yeah, it's a journey for me too. And as a lot of people in the LGBTQ community know, things are always changing. So I apologize ahead of time if I missay anything, or if I say anything unintentionally offensive. Please forgive me, but I'm trying and learning, and I have some connection with the content. I'm involved with the American Academy of Dermatology's LGBTQ-SGM, and we'll talk about terminology and acronyms in a minute, expert resource group. And I have been for a few years, and they do amazing work. So we'll get started. So the topics we'll kind of cover today is the terminology, like I just mentioned. So make sure everyone's on the same page, because I know some people are coming from the HS side of things, some people are coming from the transgender community, and some people are the overlap, and then some people are just learning everything they can, which is great. So then we'll cover general info about HS, and then we'll talk about something called comorbidities, and I'll kind of explain what comorbidities means if anyone isn't familiar. It's sort of a medical term we use. And then some other treatment considerations, and then at the end, just sort of some like miscellaneous things to think about. So we'll start off our terminology. First of all, HS is hidradenitis suppurativa. So if you haven't heard that, I'll probably just say HS for the rest of the talk, because hidradenitis suppurativa is too much. LGBT is lesbian, gay, bisexual, transgender. Of course, happy Pride Month. We got it in Pride Month before we switch over to July. And if anyone doesn't know the history of Pride Month and why it's in June, it's a really interesting story. Google it to get the full story, but it's basically 20 some years ago, the police used to raid gay bars and just beat up gay people and harass gay people. And it was just police brutality at its finest and worst. And so they went to the Stonewall Inn in New York City and decided they would just harass the people who were there, the bar goers. And when they started, the people started fighting back, and it led to a riot that lasted for a long time. And they were fighting back, and so it was sort of the first gay rights pushback. And so that's what we actually celebrate during June Pride Month, is the revolution that happened at the Stonewall Inn in New York. So it's fun to celebrate Pride Month and mark how far we've come. But it's also important to remember that it all started because it was illegal to be gay. In some places, technically, it's still illegal to be gay. And even in the US, there are still laws on the books that hopefully often aren't enforced, but there's still issues. So it's good to remember where we came from and why we're celebrating in June. And I forgot to sort of introduce myself. So Steve Daveluy, I'm from Detroit. I work at Wayne State University, and I am a cis male gay man married to my husband, who's from Canada. So LGBT, lesbian, gay, bisexual, transgender. Sometimes you'll notice there are some more at the end, like QIA2. So the Q is for queer or questioning. So it's inclusive of people who haven't really figured out their gender identity or haven't figured out their sexual orientation yet, which is an important demographic for us to remember, because sometimes there's a process of self-discovery. The I is for intersex, the A is for asexual, and then the 2 is for two-spirited or two-spirit, which is actually a term that comes from the indigenous peoples who lived in the land before colonization happened. And they considered people who were either transgender or LGBT two-spirited, to sort of kind of live between two worlds. SGM means sexual and gender minority, and that's the term that a lot of research is moving toward, because it's a nice inclusive term. Because as you can see, we sort of kept adding letters to be more and more inclusive and make sure that everybody's there. You may have noticed the pride flag has been updated. Now it's not just a rainbow, it also includes the trans pride colors and the intersex color, or the and ring, and all the colors to be very inclusive, which is really good. So that's kind of the newer term for research, and for things like the National Institute of Health, or NIH, they use SGM for sexual and gender minority. The thing about terminology is it can be complicated and it can change with time. So the word queer is a really good example, where queer used to be a slur that was used. It was used in hate crimes. And we've really reclaimed that term to sort of be an umbrella term for anybody who is LGBTQIA2, can consider themselves queer. And it's just inclusive, and it doesn't have that negative connotation that it used to have. We've sort of reclaimed it. The preferred terms do vary person to person. So some people may not like the term queer. Other people really embrace it and think it's great. So that's one of the things we always teach our residents, and I teach other physicians, is that you want to use people's personal terminology. So if they say, I'm a gay male, then you can identify them as gay. If they say they're queer, then you should also refer to them as queer, and kind of go with what people identify themselves as. And these terms and their definitions involve your identity, some biology, some behavior, and some expression, like gender expression. So it's complicated. I always tell people the most important thing is your intention. So if you slip up and say a term wrong, but people know that you're trying, and you communicate that you're trying to be accommodating and be compassionate and inclusive, people will really notice that. So sometimes if I make a mistake in clinic and use a wrong term, I go, oh my gosh, I'm so sorry. It's important to me that I use the right term for your identity. And that really means a lot to people. And of course, for as far as we've come, kind of going back to the Pride Month, we all know that there's a lot of attacks on the queer community right now, and in certain states and in certain areas of the country, where they're basically trying to make gender expression regulated and even illegal. So kind of diving deeper into a few of them. Gay is the term for someone who's emotionally, romantically, or sexually attracted to members of the same sex. So that could be male or female. Lesbian is, of course, specifically women who are emotionally, sexually, or romantically attracted to women. And bisexual describes someone who's attracted to more than one sex, gender, or gender identity. And then, like I said, queer is sort of that umbrella term for anybody who's a sexual gender minority. So basically not heterosexual and not cisgender. And transgender, well, I think it might be on the next slide. I'm getting ahead of myself. But we'll talk about cisgender and transgender. And then asexual is lack of sexual attraction or desire for other people. There's also a term aromantic for people who aren't really interested in a romantic relationship and just physical relationships. And then your sex is your sex assigned at birth. It's based on your anatomy or your sexual organs and your biology, your chromosomes. And you can be male, female, or intersex. So there are certain conditions where people are born and maybe their chromosomes may be male, but because of a change in their hormone receptors, their outward sexual organs present as female. And so that could be intersex, or sort of the in-between male, female, or sort of some differences there. Your sexual orientation is your emotional and sexual attraction to others. So you could be straight or heterosexual, gay, lesbian, bisexual, asexual. And then your sexual behavior is in terms of your partner. So a lot of times for research purposes, for publications, we'll use the sexual behavior terms. So MSM is men who have sex with men, MSW, men who have sex with women, women who have sex with men, and women who have sex with women. And they use that a lot for research because the behaviors can speak a little bit more to certain risks or differences in presentation that we see. So it gets a little tricky, but it's possible that someone may not consider themselves a gay man, but they may have sex with other men. So there are certain situations like prison, prostitution, or even if they just don't really identify as gay, or maybe they're bisexual. So they say, I'm not gay, I'm bisexual. So sometimes we use the sexual behavior terms because it speaks to the behaviors and what's involved with those. You may have heard the term homosexual. That's another one that used to be one that we use more for like same-sex behavior and identity, but now that's kind of become a little bit more of a derogatory term, so we don't use it as much. So it's another example of how things can kind of move and change with time, and it's good to be fluid. I think we're sort of used to terms changing over time. We see that not just in the queer community, but throughout our lives, that, you know, maybe a term that your grandparents used is not something that's okay to say anymore. And then your gender identity is your personal sense of being a man, woman, or other. So you could be a man, a woman, or we have a term that's gender nonconforming, or non-binary is another term that sometimes people use, because binary means there's two things, you know, it's sort of like white and black, you know, bright and dark. But there's in between. So some people are non-binary and say, you know, I don't really feel like I'm totally a man or totally a woman. I'm kind of a little bit of both. And that's a whole spectrum for people too. So that's your personal sense, how you feel, what you identify as. Like if you had never seen yourself, what you thought you were. Your gender expression is what your appearance, your personality, your behaviors, sort of what other people perceive you. So it's masculine, feminine, androgynous is another term that's for like, can't tell, gender nonconforming. So a lot of times people who are non-binary will be sort of gender nonconforming. They may have some clothing or jewelry that, you know, are traditionally thought of as being feminine, and others that are thought of as being masculine, their hairstyle and makeup. So it's really interesting how culturally gender is this construct that we have, you know, like, what does it mean to be masculine? What does it mean to be a man? You know, if you're a man, is it okay that you like to dance to ABBA? You know, things like that make us question these gender roles. And also results in things like toxic masculinity, where people, you know, criticize someone for not being manly enough and say they're a girly man, or you throw like a girl, which luckily we're moving past that, and not identifying that as a negative trait of a man to be similar to a woman, which is a whole nother topic. And then transgender means your gender identity, so what you identify as, or your expression diverges from your sex assigned at birth. So when we talk about transgender, a transgender man was someone who gender identity is a man, but maybe their biology was female. So sort of born a female physically, but identifies as a male, born as a male emotionally and mentally. And so that's a transgender man. Sometimes we use the term female to male transgender, or sometimes just to shorten things up, we say trans man. Same thing for a woman. A transgender woman is someone who identifies as a woman, but maybe was born with the anatomy of a man. So sometimes they also call that male to female transgender or trans woman. This one can sometimes trip people up a little bit, because you're once you get used to it, it's not too hard, but sometimes people get a little confused, like, well, does trans man? So trans man is someone who identifies as a man. They are a man, but their anatomy, or the way they were born, their gender was different at birth. And then cisgender is sort of the opposite side of transgender. That's where your gender identity aligns with your sex at birth. So like, I'm a cisgender male. I was born with male anatomy, and I identify as a male. So I'm cisgender. And it's kind of funny. Sometimes people go, where does this cis and trans come from? And it actually, for us science nerds, goes all the way back to chemistry and the way that molecules form bonds. If two things are lined up on the same side of a molecule, they're in a cis bond. And if they're on the other side, they're in a trans bond. So it's sort of like transformed. And then transitioning is the process to recognize, accept, or express your gender identity. It's also known as a gender affirmation process. And it is a process, and it is different for everyone. And it doesn't always go from point A all the way to point B. So there's everywhere in between, and it's kind of what people feel comfortable with, what they identify with, and it can change with time. So there may be a point where someone says, you know, I was assigned male at birth, but I identify as a female, and I'm just going to wear makeup and do my hair in a way that makes me feel comfortable to express my gender as a female, but maybe I'm not going to do hormonal therapy. Maybe I'm not going to have any surgery to change things. And that is their personal choice and what they need to do with their feelings. And as I said, sometimes that changes with time. We have this process of identifying ourselves. And I think, as we all know, our identity is based a lot on the society we grow up in, and the images that we see and things that impact the way we view the world. So it makes sense that things can kind of change. It's sort of like sometimes when you're getting in a pool at first, it's really cold, and then you're like, okay, now I'm getting more comfortable. I'm going to ease myself in a little bit more. And other people just want to keep their feet in the pool, which is perfectly fine. So now, shifting gears a little bit, let's talk about HS. So HS, or hidradenitis suppurativa, is a debilitating chronic, which chronic means long-term. It's not like an infection where it comes, you treat it, you're cured, or a cold that comes and goes. It keeps going long-term.
Yeah.
Inflammatory illness, which inflammation, hopefully people know what inflammation means. It's when your immune system is sort of ramped up. And it presents with extremely painful recurring. So that's part of that chronic and recurring. They come and they go, they come and they go. Boil-like abscesses. They can start out as little pus bumps or pustules, or sort of knots or lumps under the skin. And they can pretty much show up anywhere you have hair follicles. So we'll talk, there are some areas that are more common, but you can pretty much get it anywhere on your body except for your palms of your hands, the soles of your feet, and the part of your lips where usually people put lipstick, the kind of darker part of the lips. That's where we don't have any hair follicles. And if you aren't aware, we actually have hair follicles everywhere else on our body. So even though we're used to our big hairs, we also have what's called peach fuzz hairs. So if you look up close on someone's cheek or on the side of their neck, you actually have hairs everywhere else on your body. Just some are the big hairs and some are their little peach fuzz baby hairs. HS has a huge impact on quality of life. It is a difficult disease to live with, to deal with physically, mentally, socially, emotionally, financially. So it's a tough one. And this is why these things are so important. We need to raise awareness and bring attention to it so we can get more treatments. And I'm so happy that we're moving in the right direction. And it's an exciting time. There's a lot of clinical trials going on right now for new medications. We're learning more, we're doing more, people are collaborating. We're finally making some good progress. So it typically shows up in your early 20s or maybe your teens, but it can show up as early as adolescence or childhood. And it can also show up later in life. I have some patients who got it in their 60s or 70s. So whenever we talk about sort of these typical features, remember that that's when you look at everybody who has the disease. We say, okay, so the biggest percentage of people, it showed up at this time, but that means for other people, it showed up at different times. So even though that's sort of like the typical, it doesn't mean anything to you as an individual if that wasn't your journey. In terms of signs, you get these nodules, which are those lumps under the skin. They're sort of full of inflammation. Abscesses are similar. They're a nodule, but they have a pocket inside of them with fluid. So it's usually pus and blood kind of mixed. It can form scars and tunnels. So you can see in that lower picture, if there's sort of these scars with these little tunnels underneath. And then comedones is another word we use. It's like the medical word for a blackhead, sort of like a little plugged up follicle that's got little dead skin cells blocking it up. And so we see that in HS, and sometimes we see these comedones that have like multiple blackheads all connected. So this is where I was saying the most common locations are the armpits, the groin, around the genitals, the buttocks, and under the breasts. That means inframammary, but it can show up anywhere you have hair follicles. In terms of symptoms, the number one thing we see and the most common symptom is pain, unfortunately, and it can be so severe. If you've ever had any kind of like abscess in your skin or a boil, they really, really hurt. And then they can drain, the tunnels can drain, the abscesses can drain. There can be an odor to it. And then itch. Itch is sort of this one that is getting more attention as a symptom that we didn't really appreciate before, that it can be really itchy. And then, as I mentioned the other side, it's chronic and recurrent. So most people have a flare-up at least twice in 6 months. Not everybody, if you have a very mild case, but most people, and sadly, most people are like 2 in 6 months. I wish I get it like more than 1 per month flare-ups. But especially when it first kind of comes, it can be a little bit more spaced out, which sometimes can make it hard to catch. You go to the doctor and they think you have an infection or, you know, something else, and they don't put the pieces together. We don't know exactly how common it is. We think it's about 1 to 4% of the population. Our big problem with figuring out the exact numbers is that we think there are a lot of people out there who aren't diagnosed. And we'll talk about that on the next slide. In the Western world, like the US, Canada, Europe, it's 3 times more common in females compared to males, but that also means males get it. That means quarter of the people with it are males, and that doesn't hold true for the whole world. There are parts of the world where it's actually more common in males, so we don't understand that, but most places it's more common in females, and we think there may be a role for hormones involved, which we'll talk about more later. Studies in the US showed that it may be more common in African Americans compared to Caucasians, but it occurs in both. And because the majority of the population is Caucasian, that still means the overall number of people with it is still going to be skewed more toward it. But it just means like the relative risk, which gets sometimes research when you're looking at these epidemiology things, gets really complicated. And then more and more we're recognizing it presenting earlier. And if you talk to a lot of patients with HS, a lot of times they'll say, oh yeah, I was diagnosed at this age, but it started years before that. One of the big problems we have with HS is that there's a lot of myths and misconceptions and barriers. So unfortunately, we're trying to educate healthcare providers, physicians, and everyone to know what HS is, recognize it, and not spread these myths. But you may have even heard some of these myths from a healthcare provider. So it is not caused by shaving or by your antiperspirant or deodorant. It's not caused by tight clothing, poor hygiene, smoking, by being overweight or obese. It is not an infection of any kind, especially not a sexually transmitted infection. It's not contagious. And most of all, it is not your fault. There's nothing that you did that caused your HS. And that's one of the most unfortunate things with HS is a lot of times when patients see a healthcare provider who doesn't really know what HS is, or maybe they know what it is, but they don't really understand it. They sort of like heard about it once and know one tiny little thing. They may spread some of these misconceptions. And it's really hard when you hear a myth from a doctor or a healthcare provider, you kind of trust it and take it personally, and it causes a lot of shame and blame. So we're really trying to address this and get doctors to know what's going on. What confuses people is some of these things can flare your HS. So for some people, shaving the hair in their armpits or around their genital area may cause a flare up, or tight clothing can cause a flare up. So for some people, loose clothing causes a flare. Sometimes smoking causes flares, or friction from skin on skin, which is why we think maybe it shows up in those areas. So that kind of confuses people. When something sort of can cause a flare, it doesn't mean it's the cause of a disease. It just means it can cause a flare. And then some of the challenges we face with HS are that the big majority of patients don't see a dermatologist first. They're seeing their primary care doctor, their family doctor, their internal medicine doctor, the ER, the urgent care, their gynecologist. And so that's tough because for dermatologists, it's a very easy diagnosis. And luckily, other healthcare providers are getting really better at diagnosing it too and being aware of it. But a lot of times the awareness isn't there because they just maybe didn't hear about it during their medical training. And then because people healthcare providers don't recognize it, on average, patients see 5 different providers over 17 visits before they get a diagnosis. The reason that's a big deal is because when you have HS and you keep seeing healthcare providers who don't know what they're talking about, telling you wrong things, giving you treatments that don't work, you get really frustrated and discouraged, and you accumulate this medical trauma that makes you lose trust in the healthcare system and get jaded, because literally, why should you even keep seeing providers when no one knows what you have and no one's helping you? So it's a really frustrating and negative journey that patients have. And we're really working hard to raise awareness and to change that. The average time between when symptoms start and someone gets a diagnosis is between 7 and 10 years, which, like I said, we're really fighting that. We really want to stop it because we want to start treatment sooner to stop it from progressing. And then you can see it can have a big impact on people's ability to work, because if you have a painful flare-up, sometimes you got to take time off work. You've got to go home. So one study showed that people missed about 34 days per year from their HS. So that's like a whole month of work 10% reported that they were fired because of that. And 23% said they were passed up on a promotion because someone told them, you're missing too much work. Oops, there we go. So now we're going to shift to those comorbidities. Comorbidities is this term we use for two diseases that tend to happen together more than you would expect them to just randomly. So acne is a big one with HS. People who have HS have a higher risk of having acne. The two things happen more commonly together than you would expect them to just randomly. So it doesn't mean everybody has it, but it does mean that the risk is higher, and we see the people who have both of them not uncommonly. The reason it's kind of important when we are shifting and talking about HS and transgender patients is that both things increase your risk of mental health issues. So another comorbidity for both acne and HS is depression, and another one is anxiety. So having those diseases causes stress, which can increase your risk of mental health issues. Also, we're learning that inflammation itself can increase your risk of mental health issues. The inflammatory chemicals that your body releases when inflammation is happening can actually impact your brain and cause depression, anxiety, and other mental health issues. There's also studies that show acne can worsen gender dysphoria. Especially if people are transitioning and their hormones are triggering acne and they're sort of out of that typical acne age. That can be stressful, right? Nobody wants to be an adult with acne. Everyone feels like, this is supposed to be gone by now. I'm not supposed to have to deal with this now. So that can even make your gender dysphoria feel worse. And I forgot to talk about the term gender dysphoria. So that is when the difference between your sex assigned at birth and your gender identity causes you stress. Which obviously makes sense. If you were born one gender and you identify as another, that's stressful. It's a mismatch and it causes you stress. So that term for that is gender dysphoria. Then testosterone, like I was kind of mentioning, the hormone testosterone can make acne worse. That's why acne often shows up at puberty, because your testosterone goes up. Well, if you're taking testosterone to help with your transition, that can trigger acne. Estrogen and anti-androgens, which are medications that sort of block testosterone or block testosterone from affecting your body, can help with acne. And then that's a good thing in the sense that sometimes treatments can overlap. So if you need estrogen as part of your transition, or if you need something called spironolactone or finasteride, which are medications that sort of block testosterone or lower your testosterone or block it from affecting your skin, those can help HS, and they can help with your transition if you're transitioning into a more feminine gender expression. And so that can be a good thing, where it's kind of like, we can kill two birds with one stone. Like, your estrogen is going to help your HS calm down a little bit, hopefully. One of the challenges with HS is every treatment is kind of unpredictable until you try and see if it's going to work for you. But that's one good thing, is that if you are transitioning to more feminine, then those medications can actually help the HS. If you're taking testosterone, though, to become more masculine and as part of your transition, that could flare your HS. And there's been a few cases where that happened. There was one study that didn't show, that showed it did happen for some people, but not consistently. So again, it's a little bit of a hit or miss hodgepodge. Is it going to flare it up or not? But it is something we have to think about, that the testosterone has that potential to flare it. And then another aspect of acne is there is a medication we call isotretinoin, or the old brand name was Accutane. Now it has other brand names. And it's kind of like the super strong acne medicine that we have. The problem is it causes birth defects. And so the government made this program called iPledge, where we have to register anybody who's going to take isotretinoin. And if you have female anatomy, a uterus and ovaries, and if you're capable of becoming pregnant, you have to get monthly pregnancy tests, and you have to go through this process. It used to be really bad. They used to be very archaic in their classification and say male, female. Luckily, the American Academy of Dermatology has done a lot of work talking to the government side that runs the iPledge program and saying, we need to change these terms. I have a transgender male patient who still has a uterus and ovary, because that's where he is in his transition. So he is still capable of becoming pregnant, but he is not a female. I'm not going to register him as a female and put him through that trauma of calling him female. And so now we've got to change it to capable of becoming pregnant or not capable of becoming pregnant. So it was a big step. There's still some work to do because it's still a really burdensome program and kind of annoying. The pregnancy tests that are required monthly, if you are going to take isotretinoin, and sometimes, especially if you're transitioning to a more masculine gender expression, your testosterone might cause pretty severe acne, so you may need it. They can be urine pregnancy tests or a blood pregnancy test. So I have some patients that it's traumatic to do a urine pregnancy test when you identify as a male. So we just do a blood one. So that way it's just a blood draw. It's just your monthly lab monitoring that we're doing, and it doesn't cause so much trauma. So that's a good thing to think about if you're on that undergoing treatment with your doctor. So I alluded to this a little bit, that both HS and gender dysphoria can cause mood disorders. So you can see both diseases actually have pretty similar rates of depression, anxiety, and very, very unfortunately, suicidality, which means completed suicide or suicide attempts. And so that obviously is the worst outcome when it comes to mood disorders. And so if you think about it, if you are transgender and you have HS, you sort of have two risks for having mood disorders. So the really important thing there is to talk to your physician or your healthcare provider about your mood, any mood changes, seek help, break the stigma. Don't be afraid to ask for help and to share how you're feeling, because the worst thing in the world is when someone takes their own life and we lose that person. So we really, really don't want that. So it's an important thing to consider that, you've kind of got two things that could be increasing your risk. Then shifting gears just a little bit to talk about some of the treatments. So I already mentioned some of the things where treatment may be impacted if you're transgender and or have HS, or treatment might even impact your disease. So when it comes to gender affirming hormonal therapy, which I kind of talked a little bit about with testosterone and estrogen, androgens is sort of the blanket term that talks about all testosterone type medications. They, as I mentioned, can trigger or flare up HS. The estrogens are the feminine hormones that can help HS. And then these are those two medications I mentioned that sort of block, spironolactone blocks the testosterone receptor, so the testosterone doesn't affect your body as much. And finasteride blocks this enzyme that sort of makes testosterone or converts it to its active form. So your testosterone level kind of goes down. So both of those can help HS. So in patients who are female, we use them frequently in HS. Whether that be is cisgender female or transgender female. And actually, they use these medications as part of transition therapy too, and gender affirming hormonal therapy too, because they can kind of help your gender expression change. We sometimes use finasteride in males. We don't tend to use spironolactone in people who are firmly male. If you're non-binary, we may, depending on your gender expression, because it can sort of feminize your body. It can cause you to sort of develop more breast tissue, to lose your facial hair, which is a good thing if you're transitioning to be more feminine, not a great thing if you identify as male. And then that's why those gender goals really matter, because these things may be options depending on what your gender identity and expression is, but they may also be something that sort of is a consideration in therapy and a challenge to work around. So it's really good to make sure that you're seeing a dermatologist for your HS who you are comfortable sharing your gender identity and your gender transition journey, so that they can kind of adjust therapy or predict things that could be challenges coming up, and might even be able to choose treatments that will kind of kill two birds with one stone. Like, oh, this will help with your transition and it might calm down your HS. Let's go for this. And then before we open up for questions, just a few other things that come into play when we talk about transgender patients and HS. And one of the things, well, I'll get to it at the end. I get ahead of myself sometimes, so it's my last bullet points. So HS is common in sensitive areas, as I mentioned. So a lot of times it shows up in the armpits, the breasts, the genitals, the buttocks. So it's hard. It can be hard for anyone with HS to show those areas to their doctor. Nobody loves to take your clothes off in front of someone who's not your intimate partner. And so it can be awkward. It can be uncomfortable. It's just not something someone looks forward to. it can be extra uncomfortable if you are transitioning or even transgender, because there are other considerations there. And, and it's one of the challenges with gender dysphoria is sometimes depending where you are in your transition, looking at showing your doctor or even talking about your genitals can make you uncomfortable, because if I identify as a male and in my transition, I still have female anatomy or vagina, then I don't want to talk about it. I don't want to have a conversation about this part of my anatomy that I don't really identify with and causes me discomfort. So that's one of the things that makes HS a little more challenging for our transgender patients, is that it's this extra reason that you need to be talking about and examining these areas. And then it can affect your gender affirming surgery, your HS. So I work a lot with the surgeons who perform gender affirming surgery, because anytime HS can affect any surgery that you're having, because when the surgeon sees it, if they're not really comfortable with it, they think, I don't want to operate on that. It looks like you have an infection. Surgeons don't want to do an operation if you have an infection. And if they don't recognize HS and know what it is, sometimes they delay your surgery, they cancel your surgery. And honestly, sometimes they want it under your disease under pretty good control, just because they're worried about the healing too. If they're going to do this surgery for you, they want it to be successful. They want a good outcome. If there's a lot of inflammation in that tissue, then they worry. Maybe the sutures, the stitches aren't going to hold as well, and we're going to have complications. Maybe you're going to have more swelling, more pain, more issues. So that is something where we try to get your HS under the best control we can, both for gender affirming surgery and for HS surgery too. That's something we think about with that. We really want to have your HS as calm as possible, which isn't always, we can't always get it totally calm, but we can get it as calm as possible. And the other way it can impact your surgery is sometimes it can be another one of those opportunities to sort of do a 2-for-1 and say, all right, I'm undergoing surgery, gender affirming surgery, and I have some active HS changes in the area, like some chronic tunnels that need surgery. Can we do both at the same time? Can we sort of, while I'm in the operating room, take care of 2 things at once, which can be good. Other issues that can come up is laser hair removal can help HS. It's one of the things that's been shown to be beneficial for some people. And sometimes we do laser hair removal in preparation for gender affirming surgery. Because, when you start moving tissue, depending on where the hair is growing, you don't want hair growing in the new areas where the tissue is going to be transitioned to. So that's another one that can sometimes be a positive thing, where you go, okay, I need this laser hair removal for my transition surgery. I also need it for my HS, so we can get both. And sometimes the insurance, if you have one treatment that could be good for 2 things, it gives us 2 opportunities to ask the insurance if they'll cover it. So sometimes that's a little advantage, where you say, if you don't cover it for one condition, do you cover it for the other? And they may say yes. And then I mentioned this a little bit earlier, to just kind of share your preferences for terms, especially when your doctor's examining you, like if they're going to refer to a specific part of your anatomy and you have a term you prefer for it, or if you want to use general terms like your genitals, just let your doctor know. Hopefully you can establish that nice relationship. They know they should be using the terminology that you're comfortable with and that you identify with. And I was going to say, doctors should want to do that. So please feel comfortable letting your doctor know. I'll say, maybe if your doctor isn't comfortable with that, maybe time to see someone else, which
Oh, I think we lost him for a sec.
am I
Okay, you're back.
okay? What was the last thing I was saying?
Finding a new doctor if your doctor is not open to your terms.
Yes, thank you. So that's one of the things that unfortunately HS and transgender patients have in common, is that sometimes you find a doctor who's not a good fit. You got to find someone new. And then for some patients, I mentioned this earlier, tight clothing can cause your HS to flare. And so that can be a challenge if you're doing something like chest binding as part of your transition, is that because HS is frequently involves the armpits and the breasts, that can cause flaring, which is then this extra complication of, well, how do I do my binding and not flare my HS, which can be an issue. And then the last point I make before we can just have open discussion and questions is that we don't actually have a lot of research when it comes to HS in the transgender population. Um, they're, I wouldn't call either one of them rare, but they're uncommon enough that we just don't know enough. You know, we don't have enough. So I really hope that we can get more research going on, even if it's looking back and just talking to our transgender patients who have HS to find out what their journey was like, what treatments were helpful, what specific challenges they face. And the good news is there are some amazing HS researchers who are interested in this topic and interested in learning more. And for both HS and transgender patients, community and connection are key. Meeting other people who have a similar experience to you makes a world of difference. So you know that you're not alone. You're not the only one going through this experience. And there's someone you can talk to and share things. So that's why websites like HS Connect and the community there are so key. Like, get out there, talk to people, connect with people, even if it's online and you never are comfortable speaking face to face, it's still beneficial because we don't want you to feel alone. And with that, we can open it up for questions and discussion. And thanks everybody who was able to make it live. Thanks everybody who's watching the video later. Just so excited that we have a space for this.
Me too. Thank you so much. That was so enlightening. I mean, even just from like the beginning, because I'm out of the realm of understanding everything. So that was like very helpful for me. Because I want to, like you had mentioned, I want to treat people respectfully and don't want to disrespect anyone like that. So that was really helpful for me to better understand, just so that we can come from it at the right angle. And I completely agree that we don't have enough of these discussions for these GSMs, basically, that we need to start having more conversations about this and making a safe space where people can come and ask questions and talk. Because I think there's enough challenges we face as the general population with HS, but then all of the subgroups of population are all facing individual challenges. So very, very enlightening. Thank you so
Yes.
much.
Yeah, and that's such a good point you bring up, Brenly. There's these subpopulations of people who have HS and are younger than usual, older than typical, transgender, transitioning. Like we've got to learn more, talk more, and create space.
Yeah, and I think especially just because HS is so new as far as being under the microscope and people actually starting to care about it, that we're at such the beginning stage, which actually is a really good place to be because we have so much more availability to open up and have these discussions sooner rather than later. So that all of these things are taken into account as we're going through clinical trials, that making sure that this diversity and inclusion is also accounted for.
Yes.
You know, when we're doing clinical trials and making sure that all of that is represented as well. So
Yeah, that's such a good point.
yeah. So does anybody have any questions? No, I absolutely loved what you were saying about physicians too. You know, I think that it's some of this is new for people. And so I think there's a little bit of a fear that comes from not wanting to make mistakes and be disrespectful or be seen as being disrespectful. So I think that, you know, if you're comfortable to have that conversation, that's a great place to start. Because even if you're uncomfortable with it too, your doctor may be. So like you guys are on common ground having that
That's so
discussion.
true. Yes, yes. And you get the vibe, you
Yeah.
get the vibe from your doctor with anything you're talking to them about that you're like, I don't think you're a good fit for me. I'm gonna find someone else. Or like, this is great. I love that you're trying. It's just like I say with HS, sometimes I have these severe cases where like we are trying all these treatments and just like they are not responding. And they come in and I'm like, I'm so sorry. And they're like, hey, relax. Be nice to yourself. You're trying. I appreciate it. And I'm like, thank you for thinking about my feelings. Like,
Yes.
I'm frustrated too, and I don't have to live with your disease. Like, but it's crushing me. And they're like, well, I appreciate that. So yeah, common ground.
Absolutely. Meyer, go ahead.
Yeah, thank you. Very good talk. I was wondering, with to my understanding, many members of the SGM or LGBTQIA2 communities are under difficult financial circumstances due to one reason or the other, their families are one of the other reasons. So I was wondering what low cost or no cost resources we have for members of these communities within our clinics or things like that, because I'm unfamiliar if anti-androgens or laser hair removal or things like that are covered under insurance for the treatment of HS. So I guess my question would be, would things like that be covered? Are we able to support in some way? Or, if not, then maybe we could move towards nationally, getting funding for these things.
Yeah, and that's an excellent question because you're right. Interestingly, and I didn't even think about that for the presentation, is that both HS and sexual and gender minority status are associated with the higher risk of unemployment and homelessness too, because it can be harder to work if you have HS and it's flaring up. And then for the sexual gender minority community, like you mentioned, you have to come out to your family, and if they're not accepting, you may end up homeless. There's a lot of homeless youth, and so there are a lot of local resources you can look into for the LGBT community. A lot of the cities have youth centers for people who are kicked out of their home to help them and support them if they're experiencing houselessness. And they also have some resources to help you get aligned with insurance if you're not insured. So definitely seek those out in your local area. If you aren't really sure where to go for it, look for somewhere that has a pride flag and kind of ask someone there. And then, like you said, it's hard because even when you have insurance, what's going to be covered? Like, is laser hair removal going to be covered? Is hormonal therapy going to be covered? So that's always a hard one for docs because insurance coverage varies like state to state, insurance to insurance. One of the good things with HS is that there are some over-the-counter options. So if you visit hsconnect.org, Brindley has an amazing listing of all kinds of products that HS patients have reported that are helpful for them. There's a few washes, like there's one called benzoyl peroxide that's over the counter. Chlorhexidine you can get over the counter, or Hibiclens, it's kind of the brand name. And then even zinc washes. So it could be Head and Shoulders shampoo, or there's some zinc bars. There's another wash called Clean, or CLN, that's a body wash that has a study showing that it can be helpful. Sometimes the vitamin zinc can be helpful. You just got to be a little careful and try to talk to your healthcare provider if you can, because if you take zinc, sometimes your copper gets low. But there are some options out there. And so doing things like checking out hsconnect.org or the HS Foundation website, they list some options for things you can try to do if you're struggling with insurance coverage. And then, of course, trying to get insurance, like I said, through some of the community centers and resources that are available to help people out when they need it, fortunately.
I was going to mention too, the HS Foundation has a really great section of prior authorization letters. So if your physician is trying to get laser hair removal or any other kind of therapy, they already have pre-written letters that you can tell your physician about, and it kind of takes some of that legwork away from them. They just like slap your name on it and then away it goes. So, and it's already got all of the research backing it and everything. So that's another place that you can use if you have a physician trying to get anything like that approved. That's a good place to start too, because they don't have to put in as much work since it's already been done for them.
Yes.
And I think if it's, to your point that you made earlier, if it's treating multiple things that are going on for the patient as well, then you kind of have like double reasoning as to why that would be beneficial.
Right. Yes, that is an excellent point. Thank you, Brindley.
Mohammed, go ahead.
Thanks, Dr. Daveluy. This was such a wonderful talk, and thanks, Brindley, for hosting this. Just a question. Any recommendations how to invite this truly diverse community to participate in clinical research for HS, given like the potential medical trauma they have experienced in the past?
That's a really good question. And that's one of the things that we're navigating for all kinds of marginalized populations who have experienced medical trauma. Some of our minority groups have experienced discrimination, even experimentation in the past, is building that trust. Because research can be kind of tricky. There's that phrase like, I don't want to be a guinea pig. And no offense to guinea pigs. But so it comes from this idea of like, we don't want to be experimented on, but at the same time, research is what drives innovation. And if done correctly, and luckily there's a lot of regulation now to make sure research is done properly and correctly and safely with consent and with considerations for safety and confidentiality, it's a huge benefit to not only yourself, but your community. And I'll say my experience is that a lot of my HS patients are very eager to help with research. They really want to help the cause. Of all the diseases I treat, I think they are the most willing to help others, which is phenomenal. And the same thing so I think we've got a lot of work to do, sort of building bonds with the community, reaching out to community centers or to community organizations or to patient organizations, the message is sometimes received differently depending who gives it. So if I'm saying, please help with research, they're like, well, you're doing the research. What's going on here? But if like HS Connect says, please help with this research, it will help our community, it just feels a little different. Or if we do it together, that's even better, So I think that's one of the things we really need to do, is to do things like this, get the message out there that we care about you. We care about you as someone who is experiencing two different health situations. We want to know more. We want to do better. We want to be able to help people and to know what's going to be the best treatment for you and your specific condition. So I think that's one of the things we got to really reach out and make people feel included and welcome, and make people understand too why it's important and why we want to be inclusive, because sometimes that's a little tricky too, when people feel like, well, why are you targeting my community now for this? And we want to make sure we get the messaging right, that we're not targeting a community. We want to be inclusive. We don't want to leave your community out of the research. And especially like we were talking with HS, where these hormonal therapies can play a role and influence things. It's important that we know that, it's kind of one of the examples I always give is pregnancy. Like we don't do a lot of research in people who are pregnant, understandably, because we want to, protect the baby. But then if anyone has ever been pregnant, if you get any kind of illness, it's like, well, not much we can do. You can't take any medication right now. You can take a Benadryl if you really get sick or anything, or like an antihistamine. But that's it. And so it really leaves you feeling like, well, I don't have any options. What can I do? So it's important we have that research. And I think, sharing with people that's why we want to make sure we're so inclusive.
That was such a great point, because we're working on doing a webinar series about clinical trials and like demystifying clinical trials. So it's interesting because I have an entire section of that's going to be devoted to diversity, but more skin of color based. So you brought that up, and I actually wrote it down on here because we need to broaden that to include all of these discussions, and that needs to be wider. So thank you for bringing that up, because that absolutely is something that we need to cover during that as well. So I'm going to change gears a little bit on that and make sure that we're hitting all of these notes, because it is so important. And I think, to your point, we don't want to appear as though we're targeting, but we want you to know how important you are.
Yes.
You are so important to this research because of multiple factors, and that you can absolutely help your community in both sides at the same time. I'm really glad that you brought that up. Seriously, it was like, oh, okay, we need to do better at this. So that actually just made me do better.
I love it.
Yeah. So definitely, that's a very, very valid point. I appreciate it.
Yes.
So does anybody have any other questions? No? All right. Well, with that, it's Friday evening. Go enjoy. Thank you so much, Dr. Daveluy. That was so insightful. I really, really appreciate it. And thank you guys for joining. Thank you to everybody who's going to watch afterwards. Let's have these discussions in our communities. Let's ask, let's be proactive, and make sure that we are acknowledging and including everyone. So thank you again. I appreciate it, and we'll see you next time.
Thanks, everyone.